Right, and good afternoon, everybody, and welcome to Grand Rounds at Great Ormond Street Hospital. Thanks very much to Simon and the team for holding the fort for the last 2 weeks while I've been away. It sounds like they were two very interesting Grand Rounds, and I'm certainly going to be catching up on them on video. If you'd like to catch up with previous Grand Rounds, if you missed any, or you want to share any with your friends, they are available on YouTube, the GLA YouTube channel, which is open on the internet. So anybody that you think might be interested can see them. So please do share the videos if you like to. As always, the CPD certificates from this, you can get 45 minutes of CPD plus 15 minutes of self-reflection via the RCPCH. If you send us your name via the Survey Monkey survey at the end of the Grand Rounds, we can send you a certificate if you need one. Okay, good. All right. Well, it gives me great pleasure to introduce Laura Walsh, who's head of play at Great Ormond Street Hospital, which sounds like the perfect job, doesn't it? Really, in the world, and I think I'd quite like that job as well. So, just playing as a livelihood, really, it'd be fantastic. Well, of course, it's very important to the children that we look after that they are able to play. And their title is Serious Play: Prioritising Children Wellbeing and Recovery in a Time of Pandemic. So enough of me, I'm going to hand over to Laura now, who will introduce her team as we go through, and I'm looking forward to hearing what they have to say for the next 40 minutes or so.
Brilliant. Thank you so much, Jonathan. And thank you for giving us the opportunity to present today. So a little bit about us. Play Service supports children and young people and their families engaging in healthcare interventions at GOSH, and aiming primarily at reducing the anxiety and overwhelm by increasing the everydayness of experiences and listening to and amplifying the voice of children and young people. Using an asset-based approach to the children and young person, so really focusing on what strengths can we already see that are there that can be drawn on, rather than a deficit model, which is obviously looking for the weaknesses that are there. The play team work with children and young people to keep as many of the protective factors, as we call them, intact. So protective factors could be their meaningful relationship. So who's helping them to cope well? Who's with them? Being able to exercise choice over what's happening to them, doing pleasurable things, and being able to orientate themselves through recognizable information. We pay really close attention to communication, adapting to the ability of the child that's in front of us. And I want to talk to you, next slide please, about resilience. Now, we all need children to have this so that they can access and comply with the treatments that they need, which is why they're coming to us. If they are experiencing a traumatic event when they're in clinic with you, these children who will likely be coming back are likely to be less able to cope next time round. And evidence shows that into adulthood, they're more likely to develop comorbidities and self-destructive behaviours. Resilience in relation to human development usually refers to pathways that lead to positive adaptations or development in the context of adverse experiences. So play is recognised as enabling children themselves to create experiences that are essential to the expression and refinement of basic human adaptive systems associated with emotion regulation, stress response, peer and place attachment, learning and creativity, and positive affect. So these are the same adaptive systems that, when they're functioning healthily, contribute to a person's positive mental health and well-being. A little bit about how we do that. So by making an initial assessment of need, the team facilitates children and young people to reach acceptance of treatment through playful interventions. And play is, we know, the main way that children interact with the world. And so we can use it as a tool to bring moments that matter, which lighten the emotional burden for patients, families, and our colleagues and ourselves, and soften and warm the edges of what can be a cold and harsh experience. Because of the sensitivity and uniqueness of the position on the journey of human development that children are at, they're afforded particular rights. And so the UNCRC give children those special rights. And so just to highlight a few of them, so Article 12, the children have a right to have a voice. So to have a say over decisions which affect their bodies and their futures. Article 13, freedom of expression. to express how you feel and what you're thinking. And then Article 24, really relevant. So the right to the best possible healthcare services. Article 31, which is the right, I mean, I don't have favourites, but this would be mine, to leisure and play and culture. So children have it's a human right that they have the right to relax and play. So further guidance that we draw on. And next slide, please. Yes, so we can see that the standards framework identify that in paediatric care, children must have access to a play specialist. So recently, RCPCH in their guidance for accident and emergency services explicitly stated that children must have access to a play specialist. So the play team over the last 4 months have not been removed from everybody's experience. We have shared the traumatic events that everybody has experienced, and so 30% of our team have been shielding, so they were taken out of the equation straight away. We've had to adapt and try to make sure that this common purpose that we're here for is achieved. So I'm going to hand over to Sian, and she can explain a little bit more about what we've been doing. Thank you, Sian.
Thank you, Laura. Hello, my name's Sian and I'm Deputy Lead for the Play Services. So as Laura's just mentioned, we had a reduction in our colleagues within the play team. And so we've been thinking about how we can adapt play in these circumstances. We wanted to adapt and create playful environments that not only encouraged us to think about the experiences of children and young people, but also how can we make these changes possible and accessible given these challenges. We have been able to collaborate with both clinical and charity colleagues over the last few months in response to the changing and challenging environments. Play is impactful and has a significant role in minimising trauma for children, young people and their families. Play is a powerful resource. It offers space to explore, understand and normalise, and acts as a grounding element in times of crisis. The power of play piece of work that has enabled us to extend our experiences and ideas, making it accessible to everyone, and it can be found on the Gosh Charity website. It is a resource hub, and it is created alongside Gosh Charity as an accessible platform for play ideas and activities. This offers opportunities to share, acknowledge and understand what matters to children and young people by sharing listening spaces. The hub has sections created so parents and professionals can have access to playful activities and specialised resources. We have particularly thought about COVID-19 and the impact that this has on children's fears and anxieties. And so one of the resources was created to demystify PPE, offering an opportunity to explore and understand why nurses and doctors are wearing it. But also it offers us the space to reduce nervous energy and by sharing who is underneath all of the layers in a creative and non-pressurised way. Playful connections have been so important, and they have been possible even when we're not in the same space or same building or room as children and young people. We have been able to set up and establish Zoom play sessions as well as baby massage sessions. This has had such a positive impact in supporting the bonding process for families. Tanya and Lauren, two of our play workers in the team, have been so dynamic in delivering these sessions and supporting others to extend their skills and knowledge. But we have also thought about extending our own communication skills. Ellie, one of our play workers, and is a Makaton tutor, has helped us think about how we communicate using signs and symbols she has shared with the team. She's also been able to share this with clinical colleagues, particularly around the opportunities to learn the signs for feelings and around the different aspects of PPE. Makaton training is now available monthly on our Gold training platform. Throughout this and how we've thought about adapting play, we've thought about creating opportunities for children and young people to play imaginatively and exploratively. Can we go back to the last slide, please? Thank you so much. As some of our play spaces have been closed at present, the creation of activity packs was the way forward. Safe and accessible and playful, these are single-use packs offering a range of creative moments. We've been able to offer children, young people and families both on the wards and our outpatient departments. And this has been a tremendous effort from the whole team in sourcing and building those packs ready for use. Lastly, could we create a space that would showcase the highlight and importance of play? A space that informs and broadens our understanding of this right to play for children and young people in hospital, to share the experience of the team and how play is impactful within a clinical setting. Instagram has given us the platform, and it has provided us to be able to do that, and so much more by us creating the Gosh Play Team page. This is a platform for opportunity, growing and nurturing connections across the world. We have collaborated with many play organisations who have reached out during this challenging time, and we continue to share our skills and knowledge in a positive way as we navigate the future. I'd like to now hand over to Denise to share some of our specialised teaching modules.
Thank you, Sian. It gives us a really good overview of what's been going on and the amazing work. And it also leads us on to a continuation of other things that have changed. And this is the increase of the MPA and swabs. So this presentation is just a taster of an MPA and swab teaching module that's been put together with the collaboration of the play team. A particular thank you to Rosa and Julie, and with the MPA clinicians. So this was to support a change in practice and to identify what we could do to help patients that were experiencing an aspirate or a swab. We discussed as a team that whilst many patients cope well, others do not. And this was about identifying and recognising the factors related to this. We acknowledge that an invasive procedure like this has a potential to cause anxiety and stress prior to, during and post-procedurally. And this is not just for the patient, it's also for the parent or carer. It's definitely not a pleasant thing to have done. And any procedure involving the nose and mouth creates increased anxiety. But we know from our team of health play specialists and play workers that their dynamic work with patients and families and the supportive measures, whether it pre-procedural prep or desensitisation that they use, we can try to make this as positive an experience as possible. And this is ultimately supporting the patient's emotional and psychological needs. We've also witnessed children and young people that had their routines turned upside down, shielding, not being able to go to school, see their friends, simple pleasure of going to the park, and many of our patients not coming in for their routine appointments. This may have a significant impact on how they deal with returning to a hospital environment. Over the years, we've implanted so many different variants to soften our clinical edges here at Great Ormond Street. We have child-friendly environments, paediatrically trained staff. We have access to play around every corner. But now our edges are slightly uncovered due to trying to keep our patients, families and staff safe. The patients are returning to staff in PPE, hazard lines marking where they can sit, perspex screens putting a barrier between them and us, and the absence of many of our play resources. And we must have all noticed the quietness that's now in the main entrance. And all of a sudden we appear to seem more clinical. This is why I think we have to have our welcome back, and it must be one of reassurance, calmness, but also information giving, which ultimately empowers our patients. I think this is why we believe that the play department training modules can help support the clinic like the MPA one and play a vital role in helping to restore our patient services. If we take a moment and think about managing our own anxieties, we know that they're often determined by our own experiences and the knowledge of the upcoming situation and how we process this then into our feelings. This is the same for our patients. The teaching model will discuss further that through our engagement and assessment, we can plan a procedure that's able to support the patient's individual needs. Part of this is when we first engage with a child or young person, and this is often the situation when we are walking from waiting room to the clinical room. These are the moments when we can build a rapport and may enable a more positive outcome. I know we're all conscious of time, but in reality, this can only take a few seconds. Recognising that a child has sparkly shoes or carrying a cool rucksack lets them identify that you are a person that has taken an interest in them and can engage the mood of a fearful child into a, okay, this might be all right child. We also recognise that a prepared child is likely to be more cooperative and cope better than a child who is unaware of what's going to happen and has no opportunity for questions. The simple asking of, how are you, can create the opportunities for discussions to proceed. Again, the teaching model will explore role play and use of medically adapted toys to further support their preparation. We're also exploring the use of a preparation diversionary technique display board, which ideally should be situated within the MPA clinic. This will also give opportunity for discussion and learning whilst waiting. A large part of this communication is what health play specialists refer to as distraction. You're probably already doing it, you just don't realise it. There are many different distraction tools and breathing techniques to use, but we do suggest having a practice and choose one you're more comfortable with. And this is even more important now as we are without many of our distraction resources, but these techniques and games are still effective. We're just going to now play you a quick sample of You Name game.
Can you name 5 different fruits?
Apple, grape, pear, orange, banana.
And do you think you can name 5 different farm animals?
Pig, horse, sheep, lamb, cow.
Well done.
Thank you, technology, thank you very much. And it was a great distraction as well, so it proves the point. That's just an example of how simple those things can be, and it's to include like a familiar theme-based game. Thank you, and looking forward, we hope to be able to share more teaching modules to endorse a cooperative practice. I'll now pass you to Laurie, and you can hear more about how a patient experiences a procedure and learn furthermore about preparation and distraction techniques I referred to, and how we can help pre and post procedurally. Thank you.
Thank you, Denise. I'm Lowri, a senior health play specialist based in outpatients. As my colleagues have mentioned, the hospital looks very different post-COVID. Lots of change can make an individual feel unsettled and anxious, and that's before talking to doctors and having interventions. To help children and young people feel more at ease, we've created activity packs, sealed disposable activities for all ages and abilities, as mentioned by Sian, as well as continuing to have play specialists present in outpatient areas and inpatient areas to welcome and support anxious children and young people. However, this is simply not enough. We need to work together as one team using trauma-informed care. This is being aware of a person's lived experience and adapting our practice to better support our patients and families in such a new unsettling time. To illustrate the impact of these changes are having on our patients and families, I'm going to share a case study. Patient H, who I'll refer to as H throughout, is 6 years old. H, mum and dad arrived to his appointment, but only mum was able to go inside with him. H was already anxious due to not having dad with him as usual, and then faced multiple changes to his normal hospital experience. Lots of people in masks, big plastic screens, no toys, and then to find out he needed tests as well. It's important to mention here that H also had some sensory issues, meaning he found interventions difficult. One of the tests he needed was an ultrasound. Mum reported that he was very distressed by the sensation of the gel, but clinicians pushed through, encouraging Mum to supportively hold him for the procedure. Despite finding this very difficult and becoming distressed, H recovered and returned to play once this was over. This was until he was told he then needed a blood test. This was the point at which I was called. H was crying, backing away from both Mum and the phlebotomy team members, and trying to hide behind furniture. Mum had also become very tearful and emotional, so I asked if we could have just some time to do some talking, and the phlebotomy team left the room to allow us to do so. H repeated he didn't want the blood test. It was just too much, not today. He was clearly completely overwhelmed by anxiety. Mum reported he'd never reacted like this in the past. She felt it was a mix of dad not being there, this being their first time out after lockdown, and the changes to the hospital setting. And this is all in addition to his usual challenges of finding the sensory overload of interventions difficult. It became apparent that H had reached his point of coping, or breached his window of tolerance, as Seagal terms it, and it would be unsafe to proceed. There were discussions around holding the patient, but I explained how this would be unhelpful and would result in a traumatic experience for both mum and H, making future interventions very difficult. As a result, the clinical team agreed it was clear it was not appropriate, and we reached H's coping capacity today, and that the bloods could be taken in 3 months at his next appointment. And a procedural plan was also made with H and mum. So on to the next slide, we look at lessons learned. We must remember that patients may already be overwhelmed with our new normal, or simply having to attend hospital, and they may already be showing signs of distress. This can be in many forms. They may be withdrawn, hiding away, crying, or verbally expressing their worry. It's important as clinicians that we actively think about our patients' capacity to cope with planned interventions. Don't book too many. Get the most urgent tests done first. Prioritise. Keep in mind Seagal's window of tolerance and think about the signs your patient is displaying. Are things simply getting too much? Ask for support. Book a play specialist. We can assess the support a patient needs and facilitate preparation, distraction, or desensitization, or among other techniques to extend the patient's capacity to cope or window of tolerance. Play or inherently non-clinical relational activities, or INCRA as Hamilton calls it, has been found to build rapport, reduce distress by diverting focus onto a more positive activity. This helps to regulate the nervous system, providing a sense of calm, which in turn allows them to think more clearly, respond to questions, and take direction, essentially becoming more compliant. Think about how important your tests are before you hold a child. The nature of our patients unfortunately means that this will not be a one-off visit. This is a journey, and if we push through for this procedure, there will be numerous others following that will just make 10 times harder. So what can you do if we're not available to support? Talk to the child. It doesn't matter what their age. Everyone wants to be acknowledged and felt heard. Children and young people actually have a right to be heard, as set out in the United Nations Conventions of the Child, Article 12. Explain in simple terms what you're going to do, or even better, show them. Show them on mum, dad, a doll or a teddy if they have one with them. But if this isn't possible, show them the equipment, break it down into steps, and remember simple language. A tourniquet could be a squeezy band. EEG probes could be special stickers. Talk about what they can do to help. Often giving patients a sense of control will help. Even just being still or taking big breaths, remember to say why it helps, keeping them calm or to make things go quicker. Explain to a patient, for example, a patient is supported for a COVID MPA, simply held the hand of the person guiding the tube. This was her helping, so it really doesn't need to be complex. This goes the same for choices. Even though they cannot choose to have a procedure, they can often choose how to have it. Sitting on mum's lap, laying down, having a cuddle, watching something or playing a game. I urge you to think creatively about the procedures you carry out. There's often ways that we can adapt our procedures to help children and young people cope. You can ask them if they like to look. Some children really do like to look, and as much as parents like to discourage, watching actually gives them a sense of control. Knowing this is really important because if you block the view of a child that likes to look, you may actually cause more distress. If a child doesn't like to look, they may still like to know the steps, so ask them if they want to know what's happening. And finally, talk to them. Talk to them through the procedure. Ask them about their brothers, sisters, pets, favourite colour, favourite thing to do, anything. If they're too young to have these types of conversations, you can try singing. And don't worry, I'm tone deaf, and I can tell you kids don't really care. And if anything, it's a talking point. And I promise you, if it gets your patient through the procedure, you won't care about the embarrassment of singing badly. I'm now going to hand you over to Cath, who's going to discuss about how a crisis may look.
Hello. I'm Cath Hubbuck. I'm a senior play specialist on the team at Walsh, and I work particularly across the haematology and oncology cluster group. Today, I'd like us to be considering the experiences of children in healthcare, and I'd like to invite you today to consider a different view of what we mean and understand by the idea of crisis. When considering what crisis means for children at this current time, we could be reminded of a point that's been made by safety experts and paediatricians alike, and that is that drowning doesn't necessarily look like drowning, or rather, it does not look like our imagined view of drowning. The wild, splashing, arms raised and shouting for help that we think we know, more often than not in reality turns out to be a quiet, quick event, one that goes unnoticed until, sadly, it is too late. Reflecting on this, the same could be said about our understanding of crisis. We think we know what we're looking for. We think it will be loud, announced, or obvious, a large-scale emergency perhaps, and we think that we will have a clear understanding in real time of how we would respond. We also think that we might notice the warning signs, the vulnerabilities, and that in noticing them, that would lead us to put protective measures in place. In 2017, the International Play Association, the IPA, produced a document entitled Access to Play for Children in Situations of Crisis. For context, this was around the peak time that many children were being transported by boat across the sea, fleeing for safety from war zones in Syria and Afghanistan. It is an important document that makes a clear case for children's right to play to be upheld at all times and in all places, but especially when they are facing extreme adversity. The document acknowledges that when children are in situations of crisis, they will struggle to access safe, resourced places to play. It also strongly advocates for play in itself being therapeutic for children, a supportive factor in development and an aid to coping in the face of challenging circumstances. This document is key for health play specialists because we work with children in crisis every day. Just as drowning does not look like drowning, so a crisis doesn't always look like a crisis. As Lowri's case study Child H powerfully shows us, it can and frequently does look just like a blood test or a diagnosis of disease. The child in crisis may be distressed, they may be noisy, or they may just be quietly sitting in the waiting room, anxiously anticipating what will happen next. Back in 2017, it felt hard to push the message of the IPA document because crisis seemed too strong a word. After all, surely a situation of crisis refers to life in a war zone or a refugee camp or the aftermath of a violent natural disaster, not an illness or an injury or just a simple blood test. These are everyday events. These everyday, ordinary events surely do no harm. However, within the document was an explanation that validated the everyday, ordinary crises faced by children and young people in healthcare settings and hinted at the ongoing long-term effects that these can have. The acknowledgement that everyday hazards can have as great or an even greater impact on children's lives than a one-off large-scale disaster was as devastating as it was refreshing to read. As was the acknowledgement that such things are often misguidedly not discussed as being situations of crisis at all. These past 6 months of facing COVID-19 head-on has brought into focus a view of crisis that previously may have gone unacknowledged. A more open discussion has emerged around what situations of crisis may look like and may mean for children and for their families, with the smaller everyday hazards now squarely in the spotlight. In the wake of COVID, Western societies have had to acknowledge both how the immediate threat of illness and how separation from key relationships and playful activities have affected children's well-being and attainment, both now and how that may continue to affect them in the longer term. Throughout this time, the focus globally and locally has been understandably very COVID pandemic orientated. And as a play team here at Gosh, we've looked at this with interest because these exact considerations are everyday and ordinary for hospital play staff. The world's view may have expanded, but for play teams like ours, this is our everyday. It is familiar, it is urgent, and it is what health play staff are here to attend to. Play staff have long acknowledged that everyday hazards exist for children when they have health concerns, and that the hospital setting is risky for them in the short, the medium, and the long term. Pre-COVID, it felt more difficult to apply the term crisis to the everyday hazards faced by children felt overly dramatic somehow. Maybe it still does. But perhaps it is helpful to consider what the definition actually means. The term crisis has its root in the Greek meaning to separate. It's as simple as that. Therefore, the risks to children in hospital are best understood when a situation of crisis is acknowledged as an actual or a potential risk of separation from circumstances that otherwise help to foster a sense of safety, that enable optimal development to continue, or that allow children to have agency, that is, a degree of choice or control within their own lives. Seen in these terms, and contrasted with Sian's earlier observation that human connection really matters, we can see that the risk of harm from such types of separation is really high for children when they become sick and when they enter the hospital environment for treatment. Major motivation of health play staff is the drive to help children cope as well as possible in the face of very difficult circumstances, and often directly in the face of pain and fear. By virtue of their training, play staff understand that being sick and being made well is stressful for children in itself. The IPA document also gives a renewed emphasis to our knowledge that when children face situations of crisis, they often struggle to access play that would otherwise naturally present as a buffer or a safety net to their distress. Children recovering from major surgery cannot necessarily express verbally or easily how they're feeling. They can't necessarily ask questions or contribute to decisions about their treatment, but they may find ways to do this while they are playing. However, the physical restrictions of illness mean they often can't just easily hop out of bed to visit the playroom and then immerse themselves in this familiar therapeutic activity of playing. Children in hospital need play staff to be present and to make it possible for them, no matter how physically restricted they are, to play or how unwell they are feeling. They need the play to be brought to them or for them to be brought to the play. The adversity that children face when they are ill or injured immediately means that they are disadvantaged in terms of accessing the support they need. The drive and the need to play has an extra sense of urgency for many children in a hospital setting. The importance of play in hospital is not always well understood and can sometimes be underappreciated. Play is comforting, it's familiar, but it is also often dynamic and transformative in terms of how a child feels or gains a solid understanding of their own circumstances in the here and now. Health play specialists know that play and playful approaches work. They work by encouraging communication, by establishing trust, and by providing a sense of comfort and familiarity in an unfamiliar, often risky environment. The provision of play not only restores purpose and happiness to the child when they are sick, but when it is delivered by trained, knowledgeable and compassionate adults, play ultimately helps to facilitate experiences for children that over time will encourage lifelong resilience. I'm going to hand back to Laura, who's going to explain how this may look in a clinical setting.
Fantastic. Thank you so much, Cath. Okay, so just to explain, I am actually speaking for Steph. As we mentioned, that a number of our team are not quite back in the building yet, and so she's been called away to see a child. So just to explain, I'm going to deliver this in first person just to avoid any confusion. So to preempt, Steph has a unique role in anaesthetic pre-assessment, as no other paediatric centre in the UK has a dedicated place specialist in anaesthetic pre-assessment. A paragraph from the Royal College of Anaesthetists, Guidelines for Provision of Anaesthesia Services for Preoperative Assessment in Preparation, 2019, states that particular needs of children should be considered at all stages of perioperative care. They should ideally attend a preoperative clinic, staffed by nurses experienced in pre-assessing children. Children may benefit from a visit to the locality to which they will be admitted and familiarisation with the environment and personnel. There should be access to a play specialist. So the benefit of seeing children and young people prior to coming in is that I can be proactive, not reactive. As you heard previously from colleagues, intervention from play specialists is more effective at the start of the journey rather than when a child or young person is already distressed. And we can't emphasize that enough. In the pre-assessment clinic, I am able to assess a child or young person when they're in a calm state, finding out about previous hospital experiences, what they like, what they don't like, how as an organisation we can support the patient's anaesthetic journey. And as the children or the young people are calm, when they're being prepared, we're able to really talk about simple coping techniques to help them to manage anxiety, including counting, breathing techniques, things that Denise has brought up in her presentation as well. So this will empower the child or young person on the day of surgery because they've already been able to model that. Alternatively, we have patients referred to the clinic that have refused surgery due to anxiety and will adopt an MDT approach with nurses, anaesthetists, and in some circumstances, psychology. That's another thing to emphasise. The joint working that comes from our team is such a powerful and beneficial asset. So I'm going to give you an example of this is when I worked with a 6-year-old boy who had refused ophthalmology surgery. He was referred to anaesthetic clinic and I worked with psychology to build a rapport with this child by carrying out medical play sessions to observe negative triggers to medical equipment, which included the anaesthetic mask, SATS probes, etc. And I took my observations to the MDT to make an informed decision regarding the best anaesthetic for the patient to reduce anxiety. What this allowed us to do was to make an appropriate, reasonable adjustment, such as moving the child earlier on the list to reduce anxiety of waiting, and also minimising the number of people in the patient's room at any one time. Through the whole process of working with the child, I was the only constant. As I was at the pre-assessment, I was there on the day of surgery, and I was able to follow that journey through, which makes the play specialist role unique. Being able to offer the continuity of being there through every stage and being a familiar person in that process. So during the pandemic, anaesthetic pre-assessment closed, with many children and young people being brought in unprepared emotionally for GA. Pre-COVID, the clinic offered visits to both the admitting ward and, on occasion, really successfully, visits to theatres, and that stopped due to COVID. But going forward, we're looking into virtual video calls, for example, over Zoom, which has worked so successfully in other areas of practice. Even though they aren't going to be physically inside the hospital, patients can see a play specialist over the video, and that can be really effective. So when they do come in for their procedure, patients understand our role, and it's another way to feel familiarised, both with our role and the environment. So next slide, please. My takeaway message here is preparation is essential to help avert a crisis before it happens. The other thing is to refer to play. We really need for our colleagues to be using EPIC to refer patients to us. Now, if you could bring us to the next slide, we've given you an example of what that looks like. We'd love these slides to be widely available. We previously had a referrals inbox, and we are phasing that out. We have EPIC and we really need to use it to its full capacity. So please, 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 to all our clinical colleagues, please refer your patients through EPIC, and we will always do our best to make sure we can support them. So just to leave you with the final slide, which will show you the references that have been drawn on throughout this presentation, and to draw the whole thing to a close. Thank you very, very much.
Thank you very much, Laura and team. That was really interesting and a real insight into what the play therapy department does. And I think a lot of it is unrecognised by a lot of us in the trust. So well done. So thank you to Laura, Sian, Denise, Laurie and Cath for that. I'm going to go to Slido. Is there any questions? I don't know if everyone there who has been presenting can stick their videos on so we can see you. And then maybe we'll go through some of the questions on Slido. I'm just going to pull them up here. We've got quite a lot of questions to go through. So I think you've just answered the first question there, Laura. The question was that you're doing a fantastic job, and they want to know how you book a play specialist for a patient. And is that always through Epic, or is there an urgent referral service available?
So the alternative to Epic, we do have an extension 8849. If you need any sort of urgent attention, please call that number, and we do regularly pick up messages on that phone. So please do leave as much detail as possible.
Fantastic, great, okay, good. And so, I mean, one of the things we do all think about is about the amount of time children are spending on devices in front of screens during, before lockdown, and certainly with lockdown and online learning and things like that. What do you view from the point of view of play and using screens to involve the children in play? And is there any sort of detrimental effect to the increased amount children are spending on their screens, do you think, at the moment? Does anyone want to take that? Sian?
Yeah,
I'm happy to start the conversation off. Yeah, I think it's really important when we talk about play, we talk about play in its entirety and how we can provide that for children. And so we have to think, when we think about adaptive play, we're thinking about how can we create playful spaces and moments when children are often isolated in a room or they're isolated in one space. And so devices and screens do have a place in how we can offer that. And certainly our Zoom sessions, our play Zoom sessions have been phenomenally, amazing at being able to make that connection through a screen. And so we do have to think about the balance, but for this period of time, certainly through these challenges, devices and how we use them in the right context has been really, really productive. I'm not sure if anybody else wants to add anything to that.
I will definitely back you up, Sian. I think our perception of what is happening when children are using screens often is wrong. The children are, there are PhDs going on right now which demonstrate that children are really expert at blending the digital world and the physical world. And it's scary for us sometimes to look from the outside with our frame of reference as something we don't understand. But one of our key messages is play is actually not always tidy, it's not always comfortable for us, but actually the children generally are the experts. I think there are sensitive periods in a child's life. So I personally feel a pang of, distress internally when I see babies, with their iPad right up to their faces. But maybe that's just me. It's there are those very sensitive periods, but I think as children get older, they can be incredibly skillful in how they're using technology.
I was going to add to that I think sometimes when children are undergoing procedures and screens are used in a sort of distraction, as a distraction tool, there's sort of a case made sometimes perhaps where purse strings are a bit tight. Why should we have a play specialist? Why should we employ a play specialist? They just need a phone, they just need a screen, that's it. They come with their own screen. We don't need somebody. I would say in that particular context, screens can be so valuable. Sometimes that's the safety net for some children, particularly children on autistic spectrum, those sorts of things. It is very powerful for them. But in distraction, the key is still a human connection. So often you'll have the child, their iPad or your iPad, a game, and you, and it's the interaction between all of those things. So I would also urge our colleagues not to think, oh, it's all right, we've got a phone, we don't need to call anybody, because actually the key thing is engaging the child. I know nothing about technology really, but I can say to the child anxiously waiting, oh, you've brought your iPad, I've never seen that game, you're the expert, you can show me. And so we go in, and the procedure starts, and they're powerful in that moment. They can tell me how to play this game, and actually it doesn't matter if I actually have played that game 25 times today already, because in that moment they can show me. So it's that human connection, and that's what matters, particularly during procedures.
Yeah, I'm totally agreeing, and I think that, as you were saying, Cath, the engagement is there, isn't it? And I think often parents will come in and say, oh, it's okay, they have their device, but it is that part of having a trained member of staff as well that initiates that conversation or that rapport we were talking about, which is the opposite of what Laura mentioned, of the kind of sit the phone there in front of the baby while we go off. And there are times, obviously, parents need to do that as well, but that's the absolute difference, isn't it, from the babysitting type element of all the other things we've explored as well.
Okay. Clearly you're dealing with some very distressed children, and when they get up to the hyperarousal state, it can be really distressing as healthcare workers to see that. I mean, what do you guys do about looking after your own resilience during these times? And do you get upset by seeing these children like that, and how do you cope with that?
Okay, I'll go first. I think, play is very intrinsic, so it's a deep element and feeling within a person that is providing the space for play, but also we are often sponges and we soak up what is happening around us with the family and our interactions with the family, as well as the interactions with the children. And if you're thinking about a 7.5-hour day, there's an awful lot of sponge soaking up throughout the day. And so we're fortunate that we are in such a collaborative and safe nurturing space in our team, as well as within the trust, that we've got avenues where we can go and have those meaningful debrief conversations, those relaxed informal chats. We are constantly checking in with each other to making sure that we're all okay. And if we identify or feel like something's shifted and is not quite right, we know where to go with that, and we know there are spaces where we can offer that level of support. But I'm a human being. We are all working in a very stressful and very emotive setting, and it's actually okay to say, can I just step back and take some time? I need to reflect on what I've done, and then I need 5 minutes for a walk so that I can then center myself and move on and support someone else.
Okay. And what do you think about development of future, or sort of the play services in the future development in healthcare? Do you think there's any major changes we're going to see from your point of view?
I'm going to jump in, but everybody else feel free to jump in after. I think that what's happened in the last 4 or 5 months is that, as Cath mentioned, and even previously to that, play has really become so much more widely understood, and so sort of, I mean, it's being studied at PhD level. There is a professor of play at Cambridge. Across the world, people are really sort of drawing on hundreds of years of evidence and thinking to kind of dig down to what is going on. I think within healthcare, increasingly we're looking at the whole person, and I would like to see, and I think as a team, we feel that even broader than how we're influencing patient care, we are influencing and would like to continue to influence cultural change, so that actually playful approaches become a dominant narrative within paediatric care, certainly in our setting. And I think that is a marker of excellence. So from my perspective, I think it's really kind of looking at, in a sense, more of the same. That it's the play as the kind of everydayness, but definitely influencing cultural change within healthcare. So that's my shot.
Good. I mean, it does seem that you're all experts in, settling children who might be stressed and anxious. And do you get an opportunity to train anybody from any other departments? I mean, the junior doctors coming in, or people performing procedures, or seeing anybody interacting with the children in the trust?
So it's really something that we're looking to develop. It happens informally at ward level. So the play specialist on the ward is forever training the newly qualified nurses, and actually, yes, the new reg is coming in. We are developing formal modules that will be on Gold, so that is material there that can be accessed. So we are formalising that process. But the team do it wherever they are. They are always doing that. So everything from HCAs onwards. That's
really good news. I look forward to seeing some of those modules myself when they come out. But sadly, I think we've run out of time now. It's gone 10 to 2, so I think we need to let everyone get back to work or their home offices. So thank you again to the whole play team. That was really instructive and really interesting. Thank you very much. And I'm going to say, if you want a CPD certificate from that, you log in via the SurveyMonkey feedback form, which is going to come up in a minute via PGME, and we can give you an individual CPD certificate if you require one. And also coming forward, so we're going to have a break from Grand Rounds for August, and we're going to resurrect them in September, so everyone have a month off. But if anybody would like to nominate or see a subject that you'd like to talk in Grand Rounds or cover, or anybody would like to volunteer to do a Grand Rounds with your team, then we are open to all suggestions, and we do welcome suggestions from everybody. But again, thanks again to the whole play team, and we'll see you everyone else in September. Okay, goodbye.
Thank you.
Thank you so
Bye-bye.
much. Bye.